It's kind of like that bubbling sound that I already talked about. Bubbling sound as air moves through fluid. Usually it's in the upper airways when we can actually hear it when it's audible, that fluid is actually kind of backed up so much from the lungs that it's kind of entering the upper airway. It really does have a tendency to kind of decrease for a little bit after coughing, such as like that smoker's cough, where you hear that lot of mucus going on, or if they do have some kind of infection, such as like a pneumonia or something like that going on in their lung, where there's pus and or mucus, they can kind of cough for a little bit, and they'll kind of resolve, or they'll have an episode of coughing. You guys listen to their lung sounds; they'll kind of resolve for a little bit, and then that rhonchi would come back. Specifically in pneumonia, left-sided congestive heart failure, this is where you guys, and possibly trauma, I guess, this is where you guys are most going to hear rhonchi. All right, so when we're talking about coarse crackles, we're going to find coarse crackles in the bronchioles, and coarse crackles are actually worse than the actual fine crackles. Okay. Well, I guess they could be. Not necessarily, all right? Kind of just depends on where that crackle started, and we really don't know to begin with. Did they start in the bronchis or bronchioles and then move to the alveoli, or did they start in the alveoli and move to the bronchioles? Okay? But really, when we hear those coarse bronchis or those coarse crackles, we are in the bronchioles. We're hearing that in the actual bronchioles of the airway, okay? If we hear the fine crackles, all right, we are in the alveoli. Okay, we're actually hearing that in the alveoli, and really, it's just kind of a volume thing, right? The fines are very hard to hear sometimes, but you guys can hear them. You're definitely going to miss the fines if you don't auscultate the full lung, right? We want to try to auscultate as many regions of the lung as we can, comparing right to left. That's really the true way that you guys are going to really distinguish the fine crackles. And then the coarse crackles are in the bronchioles. It's usually the very small. I'm not talking about the big old bronchioles, right? Like where it's actually starting to become smaller from the bronchis. I'm talking the very tail end of the bronchioles when it's about to become the alveoli. Okay. And again, so if it's really soft and it sounds crackly, we're just in the alveoli. If it sounds louder and it's a little bit more distinguishable, more than likely you guys are in the bronchioles. Okay, we describe it as a popping, cracking sound. All right, it's like rubbing two pieces of hair together and listening to that through your stethoscope. Very hard to hear, especially in the back of a moving ambulance. But make sure that you guys are listening to those breath sound videos that I put up, those audio files in your breath sounds module, in order for you to really distinguish between the two. Guys, pleural rub, this is definitely one you guys need to listen to onto the file. This is kind of rare to hear to begin with. Usually that pleural rub is due to some kind of inflammation of the actual pleural lining of the lung. Okay, this is actually where you guys can actually hear the lung rubbing up against the inside part of the chest wall. So this could be a problem with surfactant due to the infection or other things. But make sure that you guys are listening to this video or this audio file that I have in your module, so that you guys can actually hear what that sounds like. There's some kind of visual representations of some breathing patterns that you guys might come across. I'm not going to spend time on these. We're going to kind of talk about these in specific disease patterns. But a lot of this also has to do with trauma patients, which you guys probably already got with some of the PHTLS. So this hopefully is a little bit of a review, and then of course we will talk about these as we go into the disease processes themselves. Interior exam of our patient, we want to make sure that we're looking for defects in the spine. These are 3 of the more common defects. I'm not going to go over these with you guys. You guys can look these up on your own in order to get a good detailed explanation. Either way, the only thing I want you guys to really know about this is that we could have such a curvature fusion of the actual spine itself that it really affects the ability for that thoracic cage to expand. This is something that you guys are going to have to deal with at some time during your paramedic careers in order to establish an airway. Other tools that we use for helping us assess the actual respiratory system. We have our pulse ox. Remember that is unreliable in some patients, specifically CO patients. CO poisoning. Remember that CO has a higher affinity with the hemoglobin than the actual oxygen molecule does. So it's going to attach onto the hemoglobin before the oxygen does, and it's going to give us a false positive reading. Any kind of peripheral shunting, right? If our patient is going into shock and the extremities, like the fingers, are cold or whatnot, it's going to give us a false positive. Poor cardiac output is going to give us a false positive. Cardiac output being if they have a cardiac event, or if possibly we are increasing that interthoracic pressure inside the chest based on either a disease process or possibly us not using CPAP appropriately. Okay, we can increase that interthoracic pressure in the chest, which is actually decreasing the venous blood flow to the heart, which is affecting preload. So naturally, because preload is affected, cardiac output will drop. And core temperatures, like I just talked about, if those extremities are cold or they are hypothermic, more than likely that pulse ox is not going to give you a good reading. Okay. Our target saturation is 94%. Okay, we do want to have our patients at 94%, anywhere between 90 and 94% for sure. When we are thinking about doing an intubation, we want to get them pre-oxygenated as much as we can, but we do want that target goal of 94%. If we are dealing with a heart attack, new research does want us at least over 90%. We do want to be right around 90% actually for our cardiac patients. CVA and ROSC, again, at 94%. You guys will talk more about that in cardiac. And we want to intervene if they're below 94%, if they're complaining of shortness of breath, right? Let's try to get them up to that 94% as at all possible. Okay, and then capnography, again, the greatest gift given to us since the dawn of our existence. It is one of the best indicators as for perfusion. It is the closest thing that we are going to have at this point in our professions to an ABG, an arterial blood gas, that we're going to get. And it really gives us an up-to-date, minute-by-minute status of our ventilation, our perfusion, and our pH. So when we're talking about, we are able to measure for CO. Okay, most of this is done by our fire departments, at least here in the city. I think with rural, some of the private ambulance companies probably have a CO detector for them. Remember that we are famous for CO poisoning in New Mexico. Okay. We are a very poor state. We have a lot of poverty here. People have a hard time actually heating their homes. So they will turn on their oven during the winter months, get that oven nice and hot, kind of let the heat escape from the oven by opening up the door. They leave the oven on overnight and it starts building up CO in their house. Okay? But that's not just the only case, right? You know, these people that actually kind of drive around in the big vans and do like carpet cleaning for businesses. Well, that pump that they have in the back of their van, if that starts kind of malfunctioning, that can also develop CO poisoning for some people. And then, of course, if you have somebody that comes into your house with a charcoal grill and decides to light that bad boy up to do some grilling inside the house, you are spewing carbon monoxide into your home. And I actually have a personal story about carbon monoxide poison. Nothing cool about like bringing in a grill and cooking in my house, but it was actually this last winter. My family and I were asleep. It was probably about 2 o'clock in the morning, and all of a sudden I thought I heard my fire alarm go off, my smoke detector go off. So I got up and I walked out, and I couldn't get it to turn off. So of course, what do? Just like the rest of every other American hopefully doesn't do, but I did. I took the batteries out of the smoke detector and I went back to bed. That's what I did, right? So anyway, so I go back to bed. It's about a half an hour later, and all of a sudden I hear somebody pounding on my damn door, right? We're talking, this is 2:30 in the morning, okay? Nothing good comes of somebody pounding on your door at 2:30 in the morning. So I'm in my underwear, and I grab my gun, and I walk out into my living room. My whole living room is lit up with spotlights, and I can see emergency lights in the back. What the hell is going on, right? And I was talking shit in my head. I was like, these dudes got the wrong damn house. They're going to wake my ass up. I'm going to open up this door and give them some shit, right? So anyways, open up the door, and sure enough, it's our local fire department. And they said, oh, hey, Spanky, how's it going? I was just like, what do you guys want? They're just like, well, we got a call from your alarm monitoring system that there's some CO in your house. And I was like, yeah, right, come on in. My fire detector went off about half an hour ago, but I just took the batteries off and went back to bed. And they kind of looked at me funny for saying that, but it was the truth, right? And sure as shit, they came in, and I was at 80 parts per million. Okay, with CO, 80 parts per million. I felt fine. My family felt fine. I woke up my wife, and she got dressed, and they were looking around the house, and we got my daughter out of there. We got my boys out of there, and at 2:30 in the morning, my wife packed up everybody and decided to drive to Grandma's so that they can get some sleep. And I decided to stay in the house, and I cracked open all the windows while they were there, kind of air out the house. I was asymptomatic. I didn't have the cherry red lips. My pulse ox was good at like 94%. I didn't have my end tidal was good. I mean, they checked out everybody. We were all fine. Nothing big came of it, but it was my heater. My heater had gone out, and it was just spewing carbon monoxide in my house. So long story short, about $4,000 later, everything was fixed. So anyways, that's the end of my story. Sorry. But really, when we start getting above that 43 parts per million, end-tidal CO2 is considered the end-tidal CO is considered a high risk for poisoning. That's when we're actually going to start to see symptoms. History of our patients, any signs and symptoms and social stuff that we want to find out, specifically a history of drug abuse on our respiratory patients. If they are a smoker, how many are they smoking a day? Are they up to packs a day? Any kind of recent illness or recent hospital stays that they might have had. And let's go back, at a minimum, maybe a couple of weeks up to a month. Do we have any clues for kind of an infectious disease pattern, right? If this is like an allergic reaction, do they have allergies? Do they have any known allergies? Have they had symptoms like this before in the past? And if they have, did they go see a doctor for it? And what happened what were they diagnosed with, or what were they discharged with, or whatnot? And then do we have a cough that's present? And if that cough is a painful cough, if that cough is producing any kind of phlegm, and what color is that phlegm that it is producing, or sputum, I guess I should say. What color is the actual sputum that they're producing? And then devise a plan, kind of based on that information. And remember, this is all just there to help us rule out certain pneumonia processes or certain disease pattern processes. So that we're asking about allergies for our patients, prescription drugs, over-the-counter, food, animals, seasonal allergies, anything that we can ask in order to help us rule out as much as possible to see if we can pinpoint a diagnosis for our patient. We want to really ask about inhalers and nebulizers, specifically for our respiratory patients. Okay, let's ask if they've are on oxygen, if they've ever been on oxygen, and for what reason. Let's talk about if they have ever been intubated, right? Based on whatever medical diagnoses that they have. Have they had to have hospital stays because of this diagnosis? And what have they usually done in the past while they're in the hospitals? Are they currently on or have been on antibiotics? That kind of goes with as far as history, go back about another 2 weeks to about a month to see if they've just actually gotten off of something. And then especially if they say that they've been on antibiotics and the symptoms seem to be getting worse. And then if they do take steroids, or if the inhalers or medications that you do find indicate that they are on some kind of corticosteroid, or if it's just a bronchodilator or whatever it is. Remember, just because it's an inhaler doesn't mean it's buterol, right? There's all kinds of different things that come in inhalers as far as corticosteroids as well. So make sure that you guys are looking at the medications of the patient to help you guys out with your treatment procedures. Medical history, when we're asking for our patients, let's focus on acute versus chronic diseases. All right, if they do have a disease diagnosis, and they did call 911, what is making it worse now than what it usually is? Okay, how did they usually able to control this? And are they taking their medications appropriately, or are they have to? Do they have their medications? Things like that. Are they compliant with their treatment? Right? Are they wearing their oxygen like they're supposed to at night? Are they wearing their sleep apnea machine at night when they're supposed to? Does it look like the patient is being taken care of? If we're dealing with caregivers specifically, like if a patient is trached, right? We want to make sure that that area is nice and clean. It doesn't look inflamed. We're going to look at all that stuff. We want to talk about recent surgeries and if they've ever been under anesthesia and if they've had problems or complications with anesthesia. Like I said before, if they've been intubated before, we definitely want to know that. And then if they've had any previous experiences with this disease process where they have been hospitalized, or is this similar to an episode that they've had into a past, or if this is actually worse than what they've had in the past. Fast oral intake is a good thing to know because it helps you understand if there's going to be a possible risk of aspiration on your patients. All right, we can find out if it was actually maybe something that they accidentally ate that had an allergy that they didn't know that they're allergic to had something, or they didn't know that what they're allergic to was actually in that product. That could be kind of screwing with with the patient's airway and breathing, or if they've actually ingested some kind of caustic substance, if this was a way to try to hurt themselves or possibly a suicide attempt or whatnot. All right, and then try to exploit the information to find identifying clues of the diseases. All right, but guys, this is just a sample history. All right, and when it comes down to it, the more questions that you guys ask in sample, right, the better your treatment plan is going to be for your patient. And also remember, especially when we're dealing with a respiratory call, people with respiratory diseases call us when they have completely exacerbated every resource that they have at their house, right? They only call us when things are not working. So when we show up, we are already behind the 8 ball, okay? So a sample is something that you guys are definitely going to want to try to get in quicker than normal, because we want to try to get this information before our patient becomes unresponsive. And if we show up and they're tripoding, and we could see all kinds of accessory muscle use, and we can see that they're tachypnic, and even possibly getting tired, this patient could crash on you very quickly. We want to try to get as much information from this patient as possible. Now, that being said, understand that because your patient's huffing and puffing, you guys should probably think about how you're going to ask these exact same questions as yes and no, right? We don't want them to be utilizing more energy in order to answer our questions. Good basic yes and no head bobbing will do just fine for us. The list that we a very short list. There's definitely more than just this to this list, but here is a good list of questions for you guys to start at the paramedic level and asking your patients. I'm not going to read these out to you guys. You guys can read this slide on your own, and these are definitely something that you guys are going to want to add to your repertoire, specifically when we start getting into scenarios in lab. Thinking about actual risk factors, exploring risk factors for suspected diseases with patient and family. Okay, genetics, history of in the family, right? Could this be an accidental shortness of breath from maybe a possibly like a polypharm overdose? Have they started new medications? Have they changed dosages? Right? And then are there any comorbidities for our patient in the first place? Right? These are all kind of risk factors that we want to keep in mind when we're assessing our patient. This is just a reminder slide that OPQRSTU is not just for pain. You guys can use this in the respiratory system to have them help you, or have your patient help you understand exactly what is going on with them.